So you will remember from the previous session that we mentioned the 5 key questions to understand health systems. And last time we went through questions 1, 2, and 3, the boundaries, the goals, the functions. So now we're going to go to question 4, which is the key question of performance. How good is a health system, right? This is what you were trying to do. How good is it itself and compared to others? I'm just going to mention, because we're not going to try to answer the question of how do we relate performance to the functions, right? The functions are a way of explaining, well, this does better because it does these functions well. But we still don't have a full science of what configuration of functions in what way lead to better performance. So that's huge agenda for health systems research that is ongoing. We know a few things, and maybe we can talk about some of those. So we'll look mostly at this 4th question. Now, what is the point of departure? What we know, I mentioned this the last time, if there's one empirical generalization we have in understanding health systems, is that if you look across the world, countries with exactly the same income per capita and exactly the same expenditures on health per capita achieve widely different results. Right? That's just the way life is. So the question is, why? I mean, it's not because they're poor, because equally poor or equally rich countries. It's not because one country spends more on health. It's not a resource allocation issue. There's something in the health system, this black box that we need to open and understand, that says that with the same overall wealth and the same financial input, you get very different results. And what that tells us is that policies do matter. Policies matter, because if they didn't matter, we wouldn't see those variations. It also opens a huge opportunity for shared learning, because it means that countries that are very similar in resource levels, some do much better than others. So we can learn from each other, and that was the spirit of that exercise in the year 2000. Now, most commonly, what we do when we compare countries, and we always compare countries or states within a country or communities within a state, is we compare overall level of goal attainment. So if you say, my goal is to reduce under 5 mortality, and then we compare who is doing better. That's the typical way in which we do those comparisons. So, although the World Health Report generated in 2000 a lot of passionate discussion, I always told them we've been doing comparisons, all the time. And if you think about it, comparing absolute level of goal attainment, it's a little bit unfair. Because if you compare Swaziland with Switzerland, yeah, you'll find that Swaziland has higher under 5 mortality. But is that a fair comparison, given that Switzerland is a much wealthier country, has much more resources? Is that fair to the Swaziland health system? And it strikes us that not. So that's where the concept of performance becomes very important, because performance relates goal attainment with what could be achieved in that particular context. And therefore, performance is a relative concept. Goal attainment is an absolute concept. You compare absolute levels. Performance is a relative concept. So let's try to see, and this is in your reading. I'm going to summarize something that's in your readings. This relates very directly to the concept of performance. So the most simple definition is that it's goal attainment or achievement relative to resources. That's the concept of performance. So performance requires that we specify a minimum possible level of performance. Now, this is an optimistic view. This says that even if you're the worst health system in the world, if you add more resources, you'll get a gradual improvement and you will attain your goals, right? For now, let's just imagine that the goal is improving health. Remember, we have 3 goals with 5 dimensions. Remember, it's improving health, improving the distribution of health, improving responsiveness, total level, and the distribution, and then fair financing. But for now, let's just think of the level of health. Healthy life expectancy, for example. Even the worst system, if you add more resources, more money, more human resources, etc., you expect that there'll be a little bit of improvement. It's an optimistic view. Some health systems actually have a declining level of goal attainment with more resources, because you start wasting stuff, you start doing unnecessary things, and your balance of risks and benefit tilts toward risks. So, but just for the sake of simplicity, let's take the optimistic view that in the absence of a system, even anything we could call a system, or you would, if you add resources, you would do something better. And then, more importantly, you need a maximum attainable. So at each level of health systems resources, as you go up this curve, right, you are attaining more and more. But there is a frontier here. I think the other issues we're talking about, whether it's levels of poverty, the political system, cultural beliefs, these are the non-health system determinants of health, okay? What we call the social determinants of health, which are not directly under the control of the health system, okay? And although as we talked, there's a stewardship function where you try to influence, you cannot judge the performance or evaluate the performance of a health system if you are in a place where the rights of certain groups are diminished, curtailed, or the health system contributes. We know there's a very strong relationship. If you improve health, poverty drops. But there are many other determinants of poverty that it's not the health system. Land ownership rules, for example, and the political system. So, of all of those, which would be the most important of the non-health system determinants of goal attainment? Like the biggest social determinant of health in a society. Environment is one, but even more important than environment, the variable that shows the highest correlation with poverty. Poverty is important. Education is, so in the World Health Report, we adjusted, and we did actually measure this for every country, and there were two variables that were used. Income per capita, which is a measure of poverty, and literacy rates, because it's not fair to equate that with education. Education is more complex than just knowing how to read, but the indicator that we had was literacy rates. And those were meant to be proxies for everything else that we were talking about. We didn't have good indicators of cultural constraints, but education and literacy were actually used, and education is, So now, I don't want to sound, let me tell you what conceptually could be. The national wealth, the levels of poverty or wealth in a country is certainly a constraint. Education, because education talks about the extent of human capital. It's not just knowing how to read or write. There's many other skills and competencies that come with an educated population, which contribute directly through health, not just through the health system, directly to health. The endowments of a country. Someone said environment. It's more than it's the environment, but it's all the endowments. If you are in a oil-rich country, you have a different set of constraints that if you don't have those endowments. If you have natural resources or other endowments like access to ports, so typically landlocked countries are in a worse shape than none. There are big exceptions like Switzerland that I just mentioned, but in general. And then there are inertial advantages. There's a path dependency here. If you were colonized and if you were, your boundaries were drawn arbitrarily, so you're fraught with internal divisions and tribal wars and so forth, like happens in many parts of the world, there are inertial advantages or disadvantages. So conceptually, you would adjust for all of that to define the maximum attainable. And this is because what we want to do is be able to judge the performance of the health system, and none of those variables are modifiable by the health system. It's a little bit the concept at the level of quality that you wouldn't hold a real life physician responsible for everything, Not his or her errors. Those are certainly part of performance. But it's all these other constraints that you cannot deal with directly. The same thing for the national health system at the aggregate level. Now, one can talk about a concept, and it's not a play on words. You could talk about the health performance of a society, right? And judge an entire society, not just its health system, by whether it does better or worse on certain measures of health, given its level. In fact, we do that with the Human Development Index. The Human Development Index has income per capita, education, and infant mortality. And what we're doing this is, this country the society is not doing well. It has low human development. And one of the things is because all of these factors, cultural, political, economic, are leading to a situation of low levels of health. But that's not what we're doing here, although that's very important, to judge an entire society on the basis of its health levels. We're trying to take that portion of that goal attainment that we really can attribute to the health system, okay? And that's why we define a maximum attainable by adjusting for all of the non-health system determinants of health. That's the logic of this, okay? Because you want to be able to say, this is a good health system, this is a bad health system. The best health policy on earth will not change the fact that the resource endowments of a country are what they are. The best health policy in the world will certainly influence education, but it will not completely fix a broken educational system. And that's what we want to extract. What part of total goal attainment can be justifiably attributed to the health system? And similarly, just to be fair, we're not attributing everything, because we know that even in the absence of a functional health system, there would already be some improvement just because there are more resources there. So we're also not crediting the health system with this part, right? But we're also not demanding that they achieve the maximum attainable. That's a phrase in the WHO Constitution. It's very problematic, the maximum attainable standard, because it doesn't say attainable where or how. And what we were trying to do is actually operationalize. It's the maximum attainable standard of health given the non-health system constraints. Now, okay, we're on the same page. So let's compare, between this maximum and this minimum. Countries do differently. And in the paper, there's a hypothetical comparison of countries A and B. And so in our traditional way of ranking, which would be better of A and B? In a traditional way. No, right, exactly. Because, we would say, gee, B has a better level of goal attainment, higher healthy life expectancy, or lower infant mortality, whatever it is. So B is better. In point of fact, when you make it relative to resources, because A is spending so much less, and it's relative to its resources, doing probably a little bit better than B, certainly at the same level of B, okay? And this was the concept that I think was, opened the eyes of many people. And after the first shock of why is the US number 39, they understood, if you spend $1 trillion on health, relative to your investments, you are not doing so well. And then when the question comes, why? Well, because you spend $1 trillion, but a lot of it is wasted. You have all these lawsuits. You have 40 million who don't use the services. For the others, you're spending even more than that, et cetera, et cetera. So this is the main insight that I want you to take, that if we just compare on the basis of goal achievement, you can get a very misleading picture. And the idea is, we're not crediting you with what you would have attained even if you did nothing, but we're also not asking you to deal with the non-health system determinants. You, by you I mean you, health system, will be assessed in terms of your performance on how well you do in terms of the gap between what you should be achieving, given how much money you're putting into your health system, which is this, and how much you're actually achieving, which is this. And this is the gap between what's achievable, given your non-health system determinants, at this level of income, of expenditure per capita, what's achievable, this is the difference between what's achievable and what's actually achieved. And that relationship, that relative concept is the concept of performance, okay? In a sense, it's a measure of a gap, right? Performance is a measure of a gap. It's this gap. This gap is the performance of a health system. The shorter the gap, the better the performance. You can apply this framework for each goal separately. So, and in fact, if you read and you look at the appendices, there are rankings on health attainment, health distribution attainment, so measures of equity in distribution of health levels among populations, responsiveness. Responsiveness, we only did one because that was the softest part. I mean, there's no data on responsiveness in most countries of the world. And then fair financing, and that was mostly the proportion of catastrophic expenditures. Here you have out-of-pocket expenditures. It is a very, very rough indicator because, in point of fact, there are catastrophic and non-catastrophic out-of-pocket expenditures, okay? You have countries like India, where about 70, 80%, or even more, I think, is out-of-pocket, but most of that is non-catastrophic, are small payments. And you can have a lower proportion, but it is catastrophic, meaning in the definition that it uses 30% or more of disposable income. Imagine any of you, if you had to spend a third of your income in paying healthcare bills. I mean, you would be devastated. Most of us would be devastated. So that was financially. So that was the indicator of fair financing. And we ranked, and all of those separate goal attainments are possible. In addition, not alternatively, in addition, you can do a composite measure of performance, okay? And that requires weighting for a society, which of those 5 elements of the 3 goals are more important, and you give different weights, and we did surveys to do that. And the composite performance is a measure of the efficiency of the system. If you remember, last time we were talking about the overall efficiency going across the 3 goals and the 5 elements, the level and distribution. So level is quality, distribution is equity, but the totality, the composite performance, is a measure of the efficiency. Why? Because it tells you what are your results relative to the resources you are. An efficient system is the one that gets the best results given the health system resources, or conversely, that that achieves the best results relative to the best results relative to resources. So that's one clarification: separate or composite measures. And then the other is you can apply the exact same logic to subsystems of a health system. So if you wanted to take, either a subsystem in terms of geography, one state or one community, or a subsystem like the public health subsystem of a country, or the hospital subsystem, you can even apply this framework to an organization, an individual hospital or physician practice. You can actually take this at different levels. Now, just bear in mind that when you go to lower levels, the total system performance is not just the aggregation. Remember that this is the key to systems thinking, is that higher order systems are not just the aggregation, because then the parts start interacting with each other, okay? But having said that, the total system performance is not just the addition of lower level. You can actually carry exactly the same logic, and then even to the point of the individual provider, and that's Gabe's comment. And that's why I wanted to link with the previous session, and why you have the reading on the cost quality discussion by Don Abedian. So in summary, the logic of health system performance is you specify your goals, you measure the attainment of the goal, you relate it to the resources and the non-health system determinants as a constraint. You then analyze the functions that explain variations in performance. So you say, gee, the US doesn't do so well because fair financing really ranks very poorly. So you link it to the functions, and then hopefully you design policies to improve the functions so that you can improve the performance, meaning the attainment of the maximum possible level of your goals, the maximum attainable level of health, responsiveness, and fair financing. That's the logic. And in the next session, we will then use this framework to analyze health system reform, and that will take us to the dynamic view. What do you do to improve performance? Okay?